The first thing I will say is I think for many people, both lung issues and things like mechanical ventilators, we feel like, well, that's somebody else. That's not me. That's not anybody I know. I feel bad for them, but that, doesn't affect me. And what I would say is when it comes to mechanical ventilators, I would bet the majority of our listening audience have been on one because when you are in the operating room, this is what we use too. So if you've ever had even minor or major surgery that required you to be on a ventilator, probably during during surgery. So that's the first thing to realize is that, this kind of technology, these kinds of issues really affect everyone. But when we think about how we normally breathe, so we have a muscle underneath the lungs called the diaphragm. And when it contracts, it flattens out. It normally is shaped like a dome. And when it flattens, the lungs get pulled down. And as the lungs expand, it creates a negative pressure in the lung and air rushes in. So we actually call that negative pressure breathing. And then because the lungs themselves are almost like a rubber band, when the diaphragm relaxes, the lungs snap back to their normal resting position and air is expelled. So when you have patients, for instance, who have asthma or COPD, what can happen is because the air tubes are clogged or the lung tissue is somewhat destroyed and it destroys the elasticity, what can happen is the air gets trapped in the lung. And when the air gets trapped in the lung, what happens is the lungs become too big. And if the lungs become too big, the diaphragm flattens in the resting position, not in the breathing position. And then when you go to breathe, the diaphragm has nowhere to go because it's already flat. It can't go down any further. It's already dropped down into sort of its most contracted position. And so that is part of the reason why when you have certain kinds of lung diseases, it's really hard to breathe. Now, the other kind of lung disease we can have are scarring conditions. And this is in some cases what we're seeing after severe COVID. What happens is the lung becomes just really kind of like a super tight rubber band. Like it's not even really stretchy. It's just kind of tied up in knots and it gets too small. And then it can be really hard to get the air in because no matter how hard the diaphragms work, they can't get the lungs to expand to the normal size. So that's kind of the general physiology and how things kind of go wrong. And we as lung doctors drop things into two big buckets. We call them obstructive lung diseases, and that's kind of that first bucket I was just talking about, which includes asthma, and then restrictive lung diseases, which are these scarring conditions. So that's kind of how we breathe. But the mechanical ventilator is very different because it's positive pressure breathing. We are physically blowing air into the lungs and therefore, forcing the lungs to open up and forcing those diaphragms down. It is not a natural way of breathing and it is uncomfortable. And to be honest, some of the sort of unintended harm that occurs with putting people on the ventilator is that when we sedate people heavily to allow them to tolerate the ventilator because it's so uncomfortable and unnatural, we also at the same time take away a lot of the body's natural protective mechanisms to protect your airway and to just, and to move and keep your muscles strong and all this other stuff. And so those are some of the unintended consequences. The other sort of unintended consequences that we can have when we have patients on ventilators is that, believe it or not, too much oxygen and blowing the lungs up too large actually is quite injurious to the lungs. And so we have to be very, very careful to keep the breaths the right size, not to force in too much air into the lungs to overinflate them, as well as to not use too much oxygen because that can be actually quite toxic to the lungs. We have to remember we're not breathing pure oxygen on a normal basis. So this is the balance that doctors are trying to strike when we do have patients that are really sick in the ICU. And if we have no other choice, we have no other choice. It's sometimes it's that or death. But we try to be as careful as possible.